In the previous video on treatment, I went over different research approaches to testing the effectiveness of treatment and some of the challenges that are faced in doing the same. In this video, I will be going over biological and psychological treatments of major depressive disorder with a focus on serotonin reuptake inhibitors and cognitive behavioral therapy. Before going into that, I would like to add a few points regarding outcome measures of treatment effectiveness. There are three specific measures that are tested when investigating the effectiveness of treatment, and these are response rate, remission rate, and relapse rate. Let's say I administer a psychometric tool measuring depression in client A, and she scores 45 out of 50 on this psychometric tool, which indicates severe depression. Okay? Response rates would refer to the positive improvement that client A experiences. So, following a period of treatment, if client A's score on the same psychometric tool improves to 25 out of 50, which is a reduction in depression, this would indicate a positive response rate. Remission, on the other hand, is the near absence of symptoms of the disorder. So, if on the same psychometric tool, if client A scores, let's say, 5 out of 50, that would indicate positive remission rates. And finally, relapse rates indicate the returning of symptoms following previous improvement. Okay, if client A after 6 weeks of treatment went from 45 to 5 on the psychometric tool, and within the next month or next few months goes back to a score of 30 out of 50, that could be an indication of relapse of symptoms. Okay, so different researchers use different outcome measures, which then mislead or misinform us about how we view the effectiveness of a treatment. Okay, so it is important to keep a focus on what outcome measure is being tested. So, biological treatments. Biological treatments are based on the assumption that biological factors, specifically chemical imbalances in the brain, play a significant role in the development of depression. And for that reason, restoring the balance of these chemicals is the main goal, okay, and is suggested to improve symptoms of depression. Neurotransmitters are commonly attributed to depression, and these include serotonin, dopamine, and adrenaline. There's two common classes of antidepressants. Okay, the first one is monoamine oxidase inhibitors. Okay, these are a class of antidepressants that influence all three neurotransmitters that I mentioned. And these three neurotransmitters together are referred to as monoamine. So then monoamine oxidase is responsible for the breaking down of monoamines. Okay, so by inhibiting monoamine oxidase, the medicine increases the concentration of monoamine available in the synapse, okay, or available in the brain, implicating improvement in depression. One of the concerns with monoamine oxidase is that it works with multiple neurotransmitters, so it's difficult to establish that cause-effect relationship. And also because it's affecting multiple neurotransmitters, there are far more side effects to it as well. Selective serotonin reuptake inhibitors, on the other hand, focus primarily on the functioning of serotonin. SSRIs blocked the reuptake of serotonin by the presynaptic neuron, which then makes more serotonin available in the synapse. Since serotonin is known to be a mood-regulating neurotransmitter, it is then implicated that it is responsible for the improvements in the individual's symptoms. So having more serotonin available in the synapse improves one's mood, and mood is one of the major symptoms of depression, right? Low mood. So this then would improve one's mood. A common SSRI chemical is fluoxetine, okay, that is found in Prozac. In 2010, antidepressants were the second most prescribed medications in the US. About 254 million prescriptions were written, resulting in $10 billion in sales. SSRIs are found to have lesser side effects in comparison to monoamine oxidase inhibitors, okay, and other antidepressants. And this is also a strength in conducting research because we are able to isolate one neurotransmitter, and in doing that, we are able to increase internal validity and also establish cause-effect relationship between serotonin and depression. So, what we will look at next is psychological treatments. Psychological treatment, also known as psychotherapy, are process oriented interventions. They involve a therapeutic alliance between the therapist and a client, okay, within which a client's subjective experiences are addressed. There are several different psychotherapies based on the theoretical orientation one follows, okay, and this also influences how we conceptualize what causes a certain disorder, okay. But the most commonly practiced and researched psychotherapy is cognitive behavioral therapy. CBT is based on the assumption that the underlying cause of depression is maladaptive automatic thoughts, also referred to as faulty thinking patterns. So, thinking, I'm not good enough, I'm going to fail, no one loves me, are a few examples of maladaptive thinking patterns that can then influence how a person is feeling. Okay. So, CBT then focuses on identifying the client's faulty thinking patterns and behaviors, testing their validity, okay, and also replacing these thoughts and behaviors with more rational and adaptive ones. CBT as a therapeutic intervention is quite structured, okay, in the way that it approaches sessions and also the whole process of therapy. But one of its benefits is that the client still plays an active role in the process, providing interpretations themselves and also agreeing or disagreeing to the conceptualizations made by the therapist. Few techniques that are common to CBT are cognitive restructuring, behavioral activation, and pleasant activity scheduling. And within the broader umbrella of CBT, there are specific therapies such as mindfulness based CBT, rational emotive behavioral therapy, and acceptance and commitment therapy. So, there's research that directly compare the effectiveness of antidepressants and CBT when compared to a placebo condition. Okay, so the first research that we will be looking at is conducted by an organization focused on the treatments of adolescents with depression. Okay, TADS 2007. Um, the focus of this research was to investigate the effectiveness of both antidepressants and CBT. It is a multi site clinical research conducted at 13 different clinics in the US, okay, with 439 adolescent participants of the age range between 12 to 17 who have been diagnosed with major depression. The research aimed to test the short term and long term effectiveness of antidepressants and CBT on their own and as a combination when compared to a placebo condition. The research used the Children's Depression Rating Scale, okay, and focused mostly on the response rate to treatment. The research was conducted in 3 different phases. In phase 1, participants were randomly assigned to the 4 different treatment groups and received treatment for 12 weeks. The fluoxetine alone group was condition 1, the CBT alone group was condition 2, the combination of CBT and fluoxetine was condition 3, and then there was a placebo condition which involved clinical management. Okay, at the end of 12 weeks, participants in the placebo group were informed of being in the placebo group and discontinued the experiment. Okay, they were also given the option to continue their own therapy or treatment through any of the other methods, but were no longer a part of the experiment. So, participants in the other group's progress was tested at this point, and they continued their specific interventions for another 6 weeks. Stage 3 of the experiment then was the continuation treatment phase, which included the participants who had improved earlier on in the experiment. Okay, so those participants who had seen most improvement early into the experiment were the ones who were part of the third phase. They were then observed for another 18 weeks while they were on treatment. Okay, as seen in this table, the placebo group did make some improvement with just clinical management. Okay, the fluoxetine group had a more positive response rate than the CBT group when administered on their own, and the fluoxetine and CBT group, when combined, had the best response rate even in 12 weeks. Okay, at 18 weeks, the placebo group was discontinued. Okay, the fluoxetine group did make some improvement, just not a lot, okay, just about 8% improvement, whereas the CBT group made a more significant improvement and also caught up almost with the fluoxetine only group. And the fluoxetine plus CBT group did make a significant improvement from the first 12 weeks. And then 36 weeks in, the differences between all three groups kind of reduces. Okay, fluoxetine and CBT on their own have the same positive response rate at 81%, and the fluoxetine plus CBT group had the best response rate at 86%. Okay, so from these results, there are quite a few conclusions that we can make. So the first one is all the active treatment conditions were more effective than the placebo condition. And this indicates that it isn't just help seeking or any other placebo effects that resulted in the improvements, but rather there are elements in these active treatments that contributed to the improvement in the participants' depression. Okay, so second, fluoxetine showed more improvement on its own at 12 weeks in comparison to CBT. Okay, but CBT eventually at 18 weeks did catch up and has the same positive response rate at 36 weeks. These findings then suggest that antidepressants can be effective in alleviating symptoms in a short duration, okay, which can be especially useful for individuals who experience severe symptoms, okay. This would also help clients come to a point where they are better prepared for active participation in psychological treatments. At the same time, for mild to moderate cases, the need for antidepressants is now questionable based on the results, okay? As the CBT treatment group on its own had the same response rate or positive response rate, and also CBT tends to address the core concerns, okay? So there is more depth to CBT than there is to antidepressants, which just deal with the symptoms. This point is also supported by the fact that this research found that there were higher suicidal events in the fluoxetine alone group when compared to the two active treatment groups. Okay, so in the fluoxetine alone group, there was a 14.7% incidence of suicidal events as compared to 8.4 in the combination group and only 6.3 in the CBT group. Okay, so that then indicates that there was more depth and they were maybe addressing some of these problematic behaviors or concerning behaviors as opposed to the antidepressants, which only looked at the symptoms. So finally, the group combining fluoxetine and CBT had the best response rate with 86%, suggesting that a combination of treatments might be the most effective approach when it comes to treatment of depression. While there are several points of evaluation for this research and the treatments themselves, these will be discussed later on in another video. One of the major drawbacks of this research is that it only measures effectiveness while participants are on that treatment. That then means that it's not looking at enduring effect of the treatment. And this can be seen because the research does not record or investigate the relapse rates following the discontinuation of these different treatment and their combinations. Okay, so Hallen et al. In 2005 conducted an RCT to determine the enduring effects of antidepressants and cognitive behavioral therapy. So, this then complements or kind of builds upon the drawback of the previous research. The research had three different conditions, okay, of participants with moderate to severe depression. Condition one included participants who had positively responded to CBT and had withdrawn from treatment for 12 months. Condition two included participants who had responded well to medication and in that 12 months had continued to take medication. Okay, and condition three included participants who responded well to medication, but in that last 12 months were given a placebo instead of a continued medication intervention. Results showed that the CBT group has the lowest relapse rate at 31%, which was even lower than the group of participants who continued to take medication. Okay, and the group that received a placebo condition had the highest relapse rate at 76%. It can then be concluded that even though antidepressants have indicated positive response rate quicker than CBT, the improvements are only observed when a person is on medication, whereas CBT has more enduring effects beyond the therapeutic process or interventions. Okay? Additionally, the fact that there was a relapse of symptoms in the group that was still taking medication indicates that the body might have mechanisms to push back on antidepressants, okay? And it could also indicate an increasing dependence for that medication, okay? Which then means that the only way to see or maintain improvement in the individual's symptoms is increasing the dosage of antidepressants, okay? And doing that would then further increase dependence on medication, could have significant side effects, and also have an impact on the self regulatory mechanisms of the body. Okay, so the TADS and the Hallen research can be used for three different questions. Okay, first, if the question is asking you to just discuss, evaluate treatments, okay, that means you can pick whichever treatment, psychological, biological, okay. So a good approach then would be to look at both psychological and biological, and you can use these two researches, okay. You can also use these researches on questions that are asking you specifically to evaluate or discuss biological interventions or treatments and psychological treatments, okay? And in the case of a contrast question between biological treatments and psychological treatments, these two researches are also great because you're able to compare between time periods, okay? And also compare when the treatments are in isolation or when they're in a combination, and also how different treatment outcome measures influence how we understand the effectiveness of these treatments, okay? Namely with regards to response rates versus relapse rates. So what we've covered in this video is basically an introduction to biological treatments and psychological treatments with a focus on antidepressants and CBT, okay? And we have looked at two different researches to support or build an argument, okay? So what we will do in the next video is look at strengths and limitations of the research methods used in these two researches, and also the strengths and limitations of both biological and psychological treatments.